adolescent females that comes up with the most. So I've seen some males struggle with it. I've only seen like 2 heterosexual males struggle with it. Majority of males that I've seen struggle with it have either been transsexual males or like gay males that are obsessed with their weight. And a couple of those were bipolar. They weren't even, believe me, they weren't thin. And they're like, I'm anorexic, they're doing anorexic, please. Because they were overweight. So something that you want to take note of, because this is interesting, and we get into like an anatomy aspect, is that the hypothalamus contains the appetite regulation center within the brain. And so it's interesting because the hypothalamus also has a lot to do with the biochemicals serotonin and norepinephrine, and it regulates those biochemicals. So what does that immediately think and make you tie that to whenever you think about that?
Depression.
What do some of your medications do? Yeah, so whenever you think about gaining weight or losing weight in terms of your medications that you take to treat depression or psychosis, it messes with those chemicals. So depending on how the person responds, whenever they take an SSRI or an SNRI, then that's why they gain weight or they lose weight, because it's affecting the appetite center within the brain, because those chemicals regulate appetite so much. So we know that eating behaviors are influenced by what's going on around us. So do you think that our society and culture influences the way people eat and what they think about body image? So, like, what's going on today with society and culture and how it's impacting the way people look? What do you think people want to look like today? Like back whenever I was in like college and school, this is back in the early 2000s. I mean, everybody wanted to be like Kate Moss then, like kind of like where you just like blow away thin. Now it's like tiny waist and like huge ass, like Nicki Minaj, like body kind of thing. Not all bony and skinny. So I mean, it's changed. So it ebbs and flows with culture and society. And you have to think, like back in the day, like you can't really tell in pictures, it's odd, because she looks so shapely and curvy, but like Marilyn Monroe was something like a size 14, which is crazy. She was just all held in by like a girdle and stuff, and like made her have that shape like a bottle, but she wasn't like small. So the prevalence rate of anorexia is approximately about 1% of the United States population. And then of that 1%, about 10% are males. So a very small percentage are actually males. And then for females, there's a very high statistical chance that the proportion is very skewed in ballet dancers for women and then wrestling for men. Those are common areas where you see it. Then we've got bulimia. It's more prevalent than anorexia, so you're going to see bulimia more than anorexia. So how's bulimia different than anorexia? Like what's anorexia versus bulimia?
Bulimia is when you throw up after a meal, anorexia is when you just don't eat the meal.
Yeah, anorexia focuses on calorie restriction, and bulimia is that binging and purging. So bulimia is a combination of binge eating disorder and then purging afterwards. And so this binge eating disorder, that's where you have these episodes of eating significantly more than you would normally need. And this time period can go on for about 2 hours. So you like binge eat, like stuff your face for hours. I mean, that's a lot. point where your body mass index gets over, 30 or greater. This is a pretty interesting statistic. I won't test you on this, but 20 young adults, 20 years of age and older, 65% are overweight, and 35% fall in the obese range. We're a fat country. Crazy. So anorexia, a lot of people talk about anorexia and don't necessarily understand it, but it's not just trying to stay thin. I mean, these individuals with serious cases of anorexia, this is the key right here. They have a morbid fear of gaining weight. And so anorexia is the difference, and the thing that you have to pick up on is that they have a severe distortion of what they look like, as opposed to just wanting to get thinner. So when they look in the mirror, they don't see a thin person, they see somebody that's large. And so they will anorexia themselves to death. They will starve themselves. There was a story back about a decade ago about two sisters in Brazil or Argentina, one or the other, that within a month of each other, they both died from just being on a lettuce and water diet. So that one sister died from starving herself to death, and then the other one passed away a month later. So they have this gross distortion in their body image. They refuse to eat. Because what they're doing is they're throwing themselves into ketosis. I mean, they eat all their carbs, obviously, and then their body fat, and then you start eating muscle, and then you actually start eating like organ tissue and stuff. I mean, it's not healthy, obviously. So you want to, especially up here, you want to star this. So if you got a question similar to the one that was like on exam 2 about what medical conditions might the individual be suffering from. So if you saw this would kind of clue you in. So anorexic individuals, or individuals suffering from anorexia, you would see things like hypothermia, bradycardia. So if you saw vital signs on the test, like pay attention to that. Hypertension, edema, and then lanugo. You guys know what that is with the OB. What's that? Yeah, the little hairs. Metabolic changes, so things that are wrong with the endocrine system, you're going to see metabolic issues going on. Amenorrhea, the females will lose their menses. They can be very obsessed with food or try and just have utter disgust with it as well. And then your anxiety and depression are your common psychological issues that you have going on, and psychiatric issues. So when you have anorexia, which is a characteristic of the diagnosis of anorexia nervosa? B. It's the best answer because they have that morbid fear of gaining weight and that gross body image distortion. So that's a pretty good and intense distractor. Like, I can imagine people miss it on a test who are talking about it. So the distortion in body image by clients diagnosed with anorexia is manifested by the thoughts that they are fat when they're obviously underweight or emaciated. So whenever you look at bulimia, they're rapidly consuming high quantities of food that are very high in calories. They can do this over a short period of time or a long period of time. And then they self-induce vomiting, or they use laxatives, diuretics, or enemas to get rid of the food. This is incredibly unhealthy for the body and can cause a lot of problems. Esophageal varices. I mean, if you do enemas every single day, that's obviously going to be a problem. laxatives and diuretics every day, what's gonna happen to your body? Dehydration and electrolyte disturbances. So, I mean, there you're setting yourself up for cardiac arrhythmias and issues with your health in that sense. So individuals with bulimia, they may fast, and they may engage in excessive exercise. Exercise bulimia, though, is very difficult, because if you think about exercise, if you've ever been on the elliptical or like ran a mile or 2 or 3 or 4 or 5, you know, the average mile that you run, you burn like in between 100 and 135 something calories per mile. So when you think about a piece of pizza, you eat that, and that's worth like more calories than that. So it's not even like mile per slice. So I mean, you have to exercise a whole freaking ton to be able to burn off the calories that you eat. So I mean, you gotta be exercising like all day to be able to burn off all the calories that you eat. So exercise bulimia, they have to be really excessive with their exercise. So if they're doing that, you'll notice. And then the substance abuse, there's such a control issue with eating disorders. That's why individuals may turn to substance abuse. It would be interesting to do some research and find out the correlation and see which substances are most popular. But obviously they can suffer with depression and anxiety as well. And then like you guys said, here's the dehydration and electrolyte imbalances from the vomiting, the laxative use, and the diuretics. So which assessment finding would the nurse expect in clients diagnosed with bulimia? Let's skip a slide. No, yeah, right here. Most patients, right, like it says right here, most patients with bulimia are within normal weight, some are underweight, and some are slightly overweight. So this has a tendency, because they're binge eating so much, it's very difficult for them to maintain their weight and have really strict control over it. So a lot of them aren't even that thin because they're consuming so many calories. So that makes more sense now for this question. Okay, I skipped something. So what do you guys think?
D.
So with your binge eating disorder, it's kind of easy to remember bed because they can't get out of bed because they're so obese. It's like my 600-pound life. So it's an eating disorder that can easily lead to obesity. So it's like bulimia, but without the purging. They eat large quantities of food. They don't engage in any activity to get rid of excess calories. And there's a severe history of, high likelihood of a history of depression with these individuals. So when you look at eating disorders as a whole, and you look at the biological influences and the genetics behind it, there have been a lot of hypotheses that have been thrown around. Excuse me. But they think that there's a hereditary predisposition. They did a twin study related to this, and they found a 56% correlation between the twins that were separated at birth and the development of eating disorders between the two twins. They also found that even non-identical twins within the population that had family members that had eating disorders were at much higher risk for developing an eating disorder. And then they've also even broke it down to the chromosomal, like DNA level, to see if there was some linkage as well. there are all sorts of theories behind it, but it's just like with anything with depression, or anxiety, or schizophrenia, or anything with a history of it, you're at higher likelihood to develop it as well. And with these biological influences, this is something like the first slide that we went over, something to kind of take note of and remember, that there's been this speculation that there's actually a dysfunction with the hypothalamus that triggers that anorexia nervosa. But the interesting thing to take into consideration is if it was simply a dysfunction with the hypothalamus, then some of the behaviors from a psychiatric standpoint probably wouldn't be there if you really take a discerning look at it. Because they would see food and they'd be like, I don't need to eat, and that like I should be eating, I'm just not hungry. They would be processing that instead of actively choosing not to eat and trying to hide it and taking some of those types of behaviors. So, and then the big one, the serotonin and norepinephrine, because this is tied a lot to our psychopharmacologic drugs. So this leads to a huge issue with probably what? With your medications that you use to treat these patients with. If they have an influence on weight, then what do you think the anorexic and bulimic patients are going to be scared of?
Med compliance.
Yeah, gaining weight and then compliance. And then there's this connection with endogenous opioids, like receptors in the brain, releasing of biochemicals. And so they think that there could be some type of addiction and control tendencies that are tied to that. But we know that there's a high control factor that comes into play. You don't have to worry about the psychodynamic influences. Like we just talked about, the family influences play a heavy role. And you can talk about these kinds of issues with the patient, but we don't want the family to be used as a crutch to shift blame. Because remember, with our therapeutic communication and development of rapport with the patient, they need to do what in order to get better? I mean, yeah, be able to take ownership of the issue. And with an individual with an eating disorder, that's a hugely significant leap forward if they can recognize that they have a problem, that they are, too thin, that they need to eat more, because especially with your anorexic patient, I mean, they see themselves as massive, and I mean, they have a grossly distorted image of who they are and what's going on. I mean, so this is, and it's an ingrained behavior. They've probably been doing it for a long time. So I try to make it clear, there is no math. So all you need to know is what the normal ranges are. BMI of 30 or greater is obesity, and then these ranges for anorexia. They show up in a question to know like where that patient falls. Don't have to do any math. So if you're able to recognize those, you should be able to easily identify the correct answer. Like, bam, see that number, you can go right to this. So you won't have to do any nursing diagnoses or identify any nursing diagnoses on this exam, because you guys have worked on care plans for all your case studies. The client has been taking, a client is 5'8" tall and weighs 105 pounds. And the client has been taking laxatives daily and self-induces vomiting after eating, which is a priority nursing diagnosis for this patient. D, yeah. So imbalanced nutrition, less than body requirements. So they're malnourished and they're underweight, so you want to maintain their physiologic integrity. So these are some pretty lofty outcomes whenever you look at, compare it to the seriousness of this illness from a mental health standpoint. I mean, an unrealistic goal is to say you're going to achieve 100% of your body weight in the time that you're here, because you just can't gain that much weight during an inpatient setting. Even 80% is probably a little bit too lofty. But having the patient admit that there's an issue and that there's a problem, and having them start to gain some weight in a healthy fashion, because you're supposed to gain 1-2 pounds a week. I mean, that's a big step forward. And then this, having normal vital signs, blood pressure, lab values, get back towards normal limits, that's a big deal. So if you had a question about a patient on an initial admission that had what set of lab values, you'd expect this upon discharge, just think abnormals versus normals. Who might be the most appropriate to consult with before they get discharged? Registered dietitian. So they understand the things that they were doing as far as fluid loss, that's impacting their electrolytes and hurting their body. They're open to taking medications and utilizing new coping skills to reduce their anxiety. And then you want them to figure out more ways to gain control over their environment and become less preoccupied with their self. But that's kind of a touchy one. You want to do it in a very proactive and soft way, because you don't want the patient to become defensive. Because when you look at eating disorders, and when I podcast personality disorders, you'll see there's a tad bit of overlap with narcissism, but not a whole lot, but you can see where it kind of like, it blurs just a little bit. So they have some of those traits, the narcissistic behavior traits, personality traits, but I mean, they're there. They start to recognize that they're actually a small individual, and that this was a maladaptive type of action. And then when you're binge eating disorders, putting a plan in place and actually figuring out a way to sustain that plan. Sustainability is big. Anybody can do good when they're being watched by somebody in an inpatient setting, but how are you going to lose the weight and keep the weight off? I mean, even if you have lap band surgery or a gastric sleeve, I know plenty of people that have had the surgeries done and they still are big. You have to actually, because they still eat like crap. So, in the course of explaining and being a nurse educator in that role, you have to explain to the patient that serious things can happen. You can have malnutrition and all the side effects that come with that. Dehydration, your electrolyte imbalances are huge, like we said, cardiac issues because of depletion of potassium and sodium within the body. And that'll tie to your cardiac arrhythmias and bradycardia. Blood pressure is a huge issue, so they're at high risk for falls. With the hypotension, oh man, Jesus. Bless you. And then suicidal ideation is always high on the list because you're concerned for patient safety. And so, not paying attention to the nursing diagnosis, but just looking, you don't want the patient to focus on specific foods, watch intake and output. We've seen building a trusting relationship before. You don't want to argue or bargain with the client. Ideally, you want to set goals and interventions with the client in the planning process, because you're involving them in defining a treatment plan and moving forward, and so this shouldn't be an issue if they try and take steps back. You have to remind them, no, this is what we decided, you were on board, so we need to just go with what we initially decided. Same with your obesity. So you need to make sure that the patient's educated about it. Encourage a food diary. They can maybe keep track of calories and see how much they're eating in a day. And then instruction about medications. That's important for anybody, any of the things that they're struggling with, especially for your anorexic patients, your obese patients, your bulimia patients, because all these medications have side effects that might impact their compliance. With your obese patients, some of the smaller patients are already at a risk for falling, but with your obese patients, they're even more of a risk. And so if there's blood pressure medications that are involved or things that might cause hypertension or cause dizziness, they could really hurt themselves because they're already putting so much stress on their system. And with any of this that relates to low self-esteem and distorted body image, you want there to be education with everybody, the patient, also the family members and peers. Have them in a very healthy and supporting place before you leave and discharge the patient into an outpatient setting. Because there's an accountability aspect that needs to be understood before the patient moves forward, because you don't want anybody to backtrack and lose the ground that you've covered. Everybody knows about the evaluation, why it's important. If you didn't meet the goals and interventions and didn't achieve the outcomes that you wanted from what you set for your patient, then you obviously reassess and reset interventions to hopefully gain the type of outcomes that you want. And you have to take into consideration that behavioral modification, it takes time because you're going up against a very ingrained type of behavior that the patients had in their psyche set in their psyche for a long while. And so it's not only that the patient that has to take this, but the family members also have to take this under consideration as well. That some of their habits and contributions to what they were doing also has to be changed. You guys know about QSIM because you had it in 205. I'm not going to ask me about it, but you recognize it. So you want to maintain safety, work in interdisciplinary teams. You know that all this produces the best patient outcomes possible. So when you look at behavior modification, so there's all these issues about control. I mean, being able to control what you eat and having a direct effect on how you look, the correlation right there, it gives the patient a very strong sense of control over their life. So for any type of program in psychiatric treatment to be effective with these types of patients, the patient still has to feel like they're maintaining some sense of control in their existence, or the treatment will be a failure, is the theory behind this. And so you want to make sure that the treatment is discussed with the client, and that they're part of the process. Some of the problems with behavioral modification is it's often based on a reward system. And so with behavioral modification, you have to be careful, and you have to set, as a nurse or the treatment team member, you have to be really innovative in your techniques as far as setting privileges and rewards for the patient. Because we used for a behavioral modification system at Our Lady of Peace that had rewards built into it, but it was just like food or video games. So they would reassess behavior every 4 hours, and they'd be like, hey, well, you didn't karate chop Cody's neck in the last 4 hours, you get a Snickers. Okay, well, you hit Cody in the eye within this 4 hours, you don't get to play the Wii. Okay, oh, you were good this 4 hours. Now, granted, he just punched me in the face the last 4 hours, but this 4 hours you were good, so you get to pick something out of the box. So you got a bag of Doritos. Well, these kids don't do anything all day, so they just get bigger, and they're on all sorts of antipsychotics. walking Cartmans, you know, just and so if we just stuff their faces full of food and let them play video games all day, when they go to school, which is led by Jefferson County, they're in school for like 3 hours a day, and like they'll just be like, look something up about history on the computer, and they're looking at Cardi B or something, you know, it's, the teacher does nothing about it, they're sitting there playing Candy Crush. Horrible. So you have to make sure that the privileges are very innovative and very structured. We want the patient to have input into the care plan and clearly understand what the treatment choices are and have them set in stone and decide on them before you move forward. So this is an important page to focus on. I mean, what does this look like? It's kind of your standard what? If you added a few more things to it, what they'll apply. Now this one I left something in here, and it's in your book, which is crazy, I double checked. That with behavior modification, you want the client to have control over what they eat, the amount of exercise that's pursued, and whether to induce vomiting. I've never been in a facility that has allowed a patient to still vomit, so I thought that that was interesting that your book had that in there. But, so this is kind of crazy. Yeah. Most of the time with facilities, they will have a room lockout order for like 2 hours after a room and bathroom lockout over 2 hours after the patient eats. If they have to go to the bathroom, someone goes in there with them. They don't have to stand there and watch them. And so you want to make sure, again, I mean, they just keep hitting this point, that all staff and clinicians and the treatment team agree with the patient. They're both agreeing collaboratively on goals and rewards. With these types of psychosomatic issues, a lot of times individual therapy will have to be employed. So any of the patients that come into a place like Central State, for example, no matter how acute they are, even if they come from LMDC or a correctional facility, you're always going to have a psych assessment done by a psychiatrist, not just a admitting nurse or the on-duty physician, but a psychiatrist that specializes in assessments. And normally you'll be referred to a specialist if you have something like an eating disorder, and then you'll have one-on-one intensive therapy with those individuals. And so that's obviously very helpful for a patient like this, because it continues the therapy once they get out of the inpatient session. And they'll be more likely to open up to those individuals, because it can be hard in a treatment setting, because you might be the only one, you know, you're talking about 1% of the United States population. I mean, a lot of times there's not a whole group of eating disorder diagnosed individuals on a unit, so you might be the only one. And you could be with substance abuse users, mood disorder individuals, and so relating to somebody in a group setting could be very difficult. And they're not very apt to open up anyway. So this would be very helpful. Family therapy is good, because a lot of times there's a lot of blame on the family, or, you know, I started doing this because you said this type of thing. So you want to involve the family about the disorder. You want to educate them kind of preemptively before bringing them in. You have to educate them on how to maintain stability with the patient and keep them from regressing backwards, and to promote adaptive functioning within the client. This Maudsley approach, it's a restructured approach to like talk therapy. Versus talk therapy, it has a much higher success rate. It's a step system approach to therapy, where you integrate family and peers into the therapeutic process at certain stages, and it's very, very structured. And so you've got pre-education aspects that are tied into it, so the patient's ready to be introduced to certain levels of like stress whenever the family's introduced. based on evidence-based practice and controlled studies. And the problem is it doesn't define what success is, but it says that this is a 90%, has a 90% therapeutic success rate compared to this talk therapy that has a 36% success rate. So, but it would be interesting to define what the control group is as far as success. So that I don't know. So an interesting aspect and a difficult one, and because I love medicine, so I'm like, if there's a pill, take it. Make sure if you can fix it with a bottle, then go for it. Is your psychopharmacologic aspects. And there's no medication that's specifically indicated for eating disorders. They use adjunct medications for depression and anxiety, but a lot of them have side effects, like we noted, that affect weight, so these individuals are very non-compliant with medications. So there's a high rate of relapse with these types of diagnoses. I say I love medications, but when you take a step back and you look at the field of psychiatric mental health just in general, for the everyday person suffering from minor to moderate depression, mild depression to moderate depression, and anxiety and stuff, medications can be very effective. But when you look at somebody that has severe psychosis, schizophrenia, major depressive disorder, suicidal ideation on a very grand scale, you can throw tons of medications to those individuals, and from my experience, it's not, on a PRN basis, you can knock them out, you can sedate them to the point where they can't do anything, but they don't get any better. We see the same patient population just rolling through all the time, and it keeps getting bigger and bigger and bigger, and we don't have enough resources to treat them all. So psychopharmacologically, there's nothing that makes people truly get better. On the mild side, yes, it increases mood, but on the most severe cases, all we can do is just make them go to sleep, which is kind of sad when you really think about it. We can't give you a shot and then all of a sudden the patient's happy. I'm happy. No, just shut up and go to sleep. Stop punching people, go to sleep. It's not like we have a shot that all of a sudden they're just, can I get you something? It's kind of sucks. I'm going to do a med list for each of the lectures, and I'll just put them on a piece of paper, and then I'll just label them, like for sexuality, these meds, for eating disorders, these meds, and so you'll know what to expect. But like for anorexia, the big ones are Prozac, Thorazine, Zyprexa. For psychopharmacology, for bulimia, it's your Prozac, your Elavil, and your Nariel. For binge eating disorder, it's your Topamax, but that can spill over, like I would combine the two right here, for binge eating disorder and obesity. Now, Topamax actually suppresses your appetite, but these do too. You've got your Prozac, and especially this one for binge eating disorder. Your various anorexians, so that's how they're calling them anorexians, causes anorexia. It's your central nervous system stimulants, especially your long-acting ones like Vyvanse, Strattera, those types of things. This one I'm going to research before I post it because I thought Phentermine was illegal in the United States, but maybe the combination with the pyramid makes it legal. Okay, anybody have any questions about